Good morning, everyone. I'm presenting here a natural history of HSPB1 related CNT and also try to delineate a little bit a genotype-phenotype correlation in the disease. HSPB1 is a small shock protein that encompasses 3 different domains and terminal, alpha-crystallin and C-terminal domains. It is a monomer, but is active as a dimer, and in condition of normal cell quiescence, the dimer aggregate together in oligomers that are inactive, while in cell stress condition the oligomers are phosphorylated and dissociate back to dimer condition that act by preventing protein aggregation and stabilizing also unfolded proteins. In vitro evidences show that N-terminal variant disrupt the phosphorylation sites that are important for the oligomer dissociation. So here we have larger oligomers that remain inactive in cell stress condition. Mutation in the alpha-crystallin domain involve the dimerization site that are important for the protein interaction with ligands, so we have a loss of specificity for ligands and a hyperactivation of the protein. Eventually, C-terminal variants involve the oligomerization site, so we have here massive oligomers that can also lead to cytoskeletal dysfunction. And there is an in vitro gradient of severity from N-terminal to C-terminal variants, with N-terminal ones being the milder ones in vitro and C-terminal ones being the most severe one in vitro, but these have never been demonstrated in patients. HSPB1 typically causes a late onset autosomal dominant motor predominant axonal CNT or distal HMN. Some patients may have subtle pyramidal involvement that we can see with brisk reflexes, and many patients have this high CK level that are disproportionately high from what we usually see from a chronic denervation pattern in CMT. It's because HSPB1 can cause in some patients a subtle muscle involvement that we struggle to see with EMG. We might be able to see with muscle biopsy, which of course is not routinely performed in CMT diagnostic workup. And HSPB1 is quite frequent in the Mediterranean area, so in Spain and in Italy, where it's the 5th most commonly mutated gene in CMT. And also it's quite frequent in the last published cohort from UCL, as in UK there are many patients from this Indian region of Gujarat where there is a big cluster due to a founder mutation. So we perform a natural history study for HSPB1 related CNT and trying also to understand if there is a genotype-phenotype correlation in patient involving multiple Italian centers and UCL. We collected information on more than 100 patients with likely pathogenic or pathogenic heterozygous variant in HSPB1, followed up for more than 9 years. So a big amount of data. These are all the variants in the 3 different portions of the gene, with the most frequent one reflecting the presence of some clusters in Italy and in the India region of Gujarat. The onset of the disease was a motor onset for many patients. For relatively few patients, there was a sensory onset. Some of patients had at the onset an accidental finding of raised CK level in blood. The age of onset was for most of the patients between the 2nd and the 5th decade, but there were 12% of patients with an onset in the first 2 decades and 8% of patients with a very late onset after the 5th decade. The severity of the disease as assessed with CNT-ES was mild to moderate in most of the patients at baseline, but after the 9 years of follow-up, the burden of the disease, of course, increased so that at the end of follow-up, many patients had a moderate to severe disease. And this is a little bit the natural history of the cohort. You see each motor milestone with the age of occurrence and the standard deviation for each motor milestone. And in y-axis, you see the percentage, the proportion of patients that reached each motor milestone. So the onset of the disease was around 40 years of age. 81% of the patients developed during the natural history walking difficulties at the mean age of 33. After 10 years from onset, 30% of patients required a stick for walking, and 7% of patients were wheelchair-bound after around 20 years from onset. But an interesting part of the slide is also the large standard deviation reflecting probably the presence of a cluster of patients progressing in a different way one to the other. This is just a simple flux diagram showing at baseline and follow-up the proportion of patients with CNT2, distal HMN, and pyramidal involvement. So during the 9-year follow-up, around 25% of patients with distal HMN developed sensory involvement, and around 16% of patients with pyramidal involvement lost reflexes due to a worsening of the neuropathy, of course. The muscle involvement pattern was quite typical and atypical for other type of CNT, as the posterior calf was more involved compared to the anterior one in 40% of patients. So these patients typically have an onset with deficit in plantar flexion with relatively spared dorsiflexion. And on the right, you can see a muscle biopsy from the leg of a patient after around 5-6 years from onset. You can see the soleus, which is fat infiltrated compared to the tibial one, which is quite spared. And in the other, on the right, you can see a steer sequence showing that the soleus and also the lateral gastroc a little bit are brighter compared to the tibia, so they are denervating. And around 15% of patients had proximal upper limb or lower limb weakness, and around 4% of patients had this axial weakness, which was probably due to myopathy. 4% of patients then had facial weakness. This is an example of a patient with distal HMN, so a motor length-dependent neuropathy that performed around 20 years ago a muscle biopsy in the biceps because he had very high CK levels, more than 1,000. And the muscle biopsy revealed the presence of these vacuoles with aggregates inside that we know from previous studies with electronic microscopy to be myofibrillar aggregates. And on the right, you can see an ATPase staining showing that there is no grouping of fibers, so there is no neurogenic involvement in this muscle. And around half of patients who perform muscle biopsy have this mild vacuolar myopathy with aggregates. And coming now to genotype-phenotype correlation, just to remind you that previous in vitro studies found that there is a gradient of severity from N-terminal to C-terminal variants. And here, by aggregating many patients, we saw the same. So patients with alpha-crystallin domain and C-terminal variants had a higher burden of disease compared to N-terminal ones, both at baseline and last visit. And also there was a gradient of progression from N-terminal variants to C-terminal ones, with N-terminal ones being the milder ones in progression, as assessed with variation CNTES per year, and C-terminal ones being the more severe one in progression. And also looking at clinical features, patients with alpha-crystallin domain and C-terminal variants were more prone to wear AFOs, you can see down in the slide, to use a stick for walking, to be wheelchair-bound, to have difficulties in the upper limb, and also proximal lower limb weakness. And this is the natural, again, history of the cohort. If you remember, there were wide, large standard deviation reflecting the presence of cluster of patients progressing probably in a different way. And here we saw that by dividing the cohort in the three different, in the mutation in the three different domains. So patients with C-terminal mutation had an earlier onset with very rapid progression of the disease. Patients with alpha-crystallin domain mutation had an intermediate onset, age of onset, with still quite fast progression over the years. Eventually, patients with N-terminal variants had very late onset of the disease and very mild, indolent progression, so that after 30 years from onset, just very few patients required a stick for walking, and none of them were wheelchair-bound. So this is a big cohort of HSPB1 related CNT. It is a quite interesting CNT because it's very clinically heterogeneous with some pyramidal involvement, some muscle involvement. There are also some patients with a predominant myopathy, distal myopathy, which are very rare. And high CK levels and the posterior involvement of the calf compared to the anterior one are important diagnostic clue guiding diagnosis. And variant in the alpha-crystallin domain and C-terminal are more severe to the N-terminal ones, and this has an impact, of course, on patients. And I would like to thank all the centers, including the Italian centers and UCL. Thank you.
Thank you, Alessandro, for your nice insight these HSPB1 related neuropathies. Are there any questions from the audience? Steve?
So thank you for that. Just to clarify, how much sensory involvement is there in your cohort? Because to say there's clinical sensory involvement isn't the same thing as saying that there's no sural or radial sensory response. I would like to clarify that. And I'd also like to know how you or anyone can easily separate a distal myopathy from a distal motor neuropathy, because I think in this particular disease, that clarification hasn't, to my mind, been very well made.
Okay, so the first question is...
how much sensory involvement?
Okay, I don't know if... however, in the C-terminal variants, they were mainly distal HMN, and so it justified the fact that they are also more severe because so the CNTS scale didn't have the sensory item scores, so they were very severe. I don't know if I... Okay, so C-terminal variants were mainly distal HMN, and the other one, it was quite equally distributed, especially in the N-terminal ones. And for the other question, how we defined...
you haven't answered the first question. How much sensory involvement? Were there? Not too much.
No, not too much.
Not too much.
No, not too much. They are motor predominant or exclusively motor. Yeah.
And then the second harder question is that are we really confident that we can exclude the contribution of the distal myopathy from a distal motor neuropathy in these patients?
It's difficult to quantify the contribution of the myopathy because we struggle to see it with EMG because distal myopathy, so it's mainly masqueraded by the neuropathic changes. There are 3 patients that are excluded from this analysis that have mainly myopathic involvement, so which we saw it at EMG, but usually you don't see at the EMG, you just see some myopathic changes at muscle biopsy.
I think just to come back on that as well, thank you, Alessandro, that was very nicely presented. So I think we need to just get away from worrying about labels. This disease is a disease that has got a neuropathy, which is absolutely motor predominant, and probably everyone has subclinical myopathy. So in our original series, we noticed CKs were well above 1,000 on all the patients at all times. And if you start looking, I think the problem is EMG is limited if you've predominantly neurogenic. But I've no doubt it is a neuropathy looking at the neurophysiology initially in terms of the amplitudes before you get severe myopathy. The sensory is really mild, but you can lose your surals with time, more so than you would expect for age. So it is with age, I think, but it's really, really mild. I think that's the thing. But I do think probably it is a neuromyopathy, and if you look at HSP1, B8, BAG3, all of those, the alpha-crystallins, they all, you do begin to find, if you look at them, that it's a myopathy plus neuropathy, and it's a spectrum. So I think it's a neuromyopathy, which is motor predominant. So I think the way we used to classify things has probably been reductionist a bit, and has limited our diagnostic, and as we expand it with what we find, we probably need to expand what we think. And it's not a surprise when you look at where these proteins are expressed nowadays.
So, thank you very much for your presentation. I was wondering, you show a lot of missense mutation, and you show one nonsense mutation. So, for the nonsense mutation, do you know how it could work? Is it haploinsufficiency, or is it a gain of function?
No, gain of function, yeah.
You think it's a gain of function?
Yeah.
Because like it's in the exon 2, I think.
It's in the last exon.
It's in the last exon, yeah. Okay, thank you. Because I was sorry, I just finished. I was thinking, because we found, but we don't know if it's pathogenic or not,
the same variant.
A deletion of this gene, but a complete deletion. So do you think it could be pathogenic? I'm not sure about it.
No, there are also homozygous variants which are very, 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 very severe and can act by, of course, haploinsufficiency, but they are mainly gain of function mutation with the heterozygous variants.
Okay, thank you.
Thank
Thank you, Alessandro. I just genetic, just population genetics curiosity. Is there any Italian mutation associated or the same from the Gujarat in India?
Some Italian patients?
Yeah, from your
No, they are
no,
all
it's
from
completely different.
Gujarat, Indian Gujarat region.
No, my point is there, I mean, the mutations in Gujarat region is also presented in the Italian population?
No,
Not at all.
No.
That's because Gujarat is very close to the origin of gypsies. And it could be the question: what could be related to the gypsies? But the answer is not. You know, it's very close to right. Yes.
Any other question from the audience?
One question, perhaps. So I saw there was a little bit of axial weakness as well. It's quite striking that all the myofibrillar myopathies, one of the key features is this axial muscle weakness. Did you screen for it by muscle MRI or just by clinical testing? Because sometimes it's missed in these cases.
Yeah, it was highlighted by clinical testing. We did not perform in these few patients MRI of axial MRI, but of course we think it is myopathic due to the distribution, which is mainly associated to myopathic changes, the axial weakness, usually.
Other questions? One last question there. Yes, Stan?
In the muscle biopsies, you showed the vacuoles in the center of the myofibers. Those are, from what I know, usually associated with autophagy dysfunctioning. But can you maybe link that to the severity of the patient at that time? Like if you have more of them.
If it correlates with the severity?
Yeah.
No.